Good morning, everyone who's here and online. Um, Pleasure to welcome my friend, Dr. Tor BIERING-SØRENSEN. Is it good enough? Or no, this is the Danish pronunciation. He just said it to me and I knew I wasn't going to do a good job. Tor obtained his medical degree and PhD from the University of Copenhagen. He was actually here in Boston. Completed a master's in public health here, and I believe you overlapped with Jordy at the time, right? Jordy Strom, and then went on to do a master's in clinical trials at the University of Oxford. Tor is a professor of cardiology and pragmatic randomized trials at the University of Copenhagen. He's also the founding head of the Center for Translational Cardiology and Pragmatic Randomized Trials at the University of Copenhagen as well. It says in his bio that he mentors several, but if you go to a conference, Tor is usually surrounded by an army of med students, postdocs, trainees that he mentors and who all very much adore him. And he mentors them in various aspects of research, including cardiovascular imaging, randomized trials, and heart failure. He does a lot of work focused on the nexus of leveraging nationwide registries and large-scale randomized trials. And he's also conducted, his group has conducted extensive research on the usability of cardiovascular imaging to improve individualized risk prediction. Tor, and I think we're going to hear a lot about this today, has conducted several large-scale pragmatic randomized trials using nationwide registries, and really cool and innovative work that sort of brings together nudges with national data sets and pragmatic randomized trial design. So we're really excited to hear about your work. Welcome, Tor.
Thank you so much, Richie, and thank you again for inviting me. It's really a great honor to be here, and I really look forward coming back to Boston. As you mentioned, I lived here for a couple of years, and it's always been great being back in my second home. And as you mentioned, Richie, I'm going to talk about how we've until now used our nationwide registries in Denmark to conduct pragmatic randomized trials. I'm just going to figure out how to change slides. Sorry, this is my disclosures. So first of all, why do we at all need to use registries for conducting trials? One of the most important things is that, as you can see on this slide, our colleagues have done an amazing job finding 3 treatments that had lower event rates substantially over the last couple of decades. So event rates in many diseases, and especially in cardiovascular medicine, are getting lower and lower. When we do randomized trials, we are almost always only testing for moderate treatment effect. And this combined with the low event rates, trials need to get larger and larger, and the cost of and complexity of these trials become even increasing year by year. Then there has been a lot of talk about, can't we just leverage real-world data for evidence generation, assessing treatment effects? And I really like this commentary by the Oxford group titled "The Magic of Randomization versus the Myth of Real-World Evidence," where they write in this commentary, promotion of non-randomized analysis of databases as a rapid source of real-world evidence about the effects of treatment is a false solution to the problems caused by the bureaucratic burdens imposed on randomized trials. So figuring out a way to combining the real-world evidence with randomization seems to be a logical solution. How can registries improve the conduct of trials? They can be used to identify eligible patients for a study. They can be used for patient screening, for patient enrollment. Direct contact to patients through registries seems as an optimal solution. We can use them to record patient consent. We can randomize patients directly within our registries. We can obtain information about baseline characteristics through the registries, and we can also follow our patients that we randomize through the registries both within trial but also post-trial. And we can follow up patients that were excluded from the study within the registries. Furthermore, it reduces the burden on the site staff, on the participants of the trials. Registries enable novel trial designs, as mentioned, direct-to-patient trials, embedded registry trials. And because we can do trials for lower cost, we can do them larger. So PI-initiated trials can actually be done sufficiently powered. That is often an issue, that we don't have enough budget, enough money to do large enough trials. So we often do underpowered trials when industry is not involved. And besides doing larger, sufficiently powered trials, we can do more trials. Registries enable the additional questions to be answered, additional subsidiary outcomes to be assessed, assessment of long-term effects of treatments, and it improves the quality because we have the potential for complete unbiased follow-up. In general, we stratify our registries into two types. We have our administrative registries and our clinical registries. So the administrative registries, it's our population registries, our nationwide registries, and here in the US, the claims databases, and the type of data that we have in these administrative registries, and you guys know probably much more about this than me, is hospital admission, outpatient visits, diagnosis, medical procedures, prescriptions. And if we look at the clinical registries, they are often disease-specific, so it's disease registries, quality registries, clinical data registries. And the type of data that we often have in these registries are disease-specific biomarkers and classification, and detailed disease and clinical specific procedures. So the registries that I've worked most with is the Danish nationwide registries. And you know, every time I do a new study within these registries, I figure out that additional registries exist. And just from working with colleagues in this room, you know, we learn about how we can leverage these nationwide registries every time we do a new research project. The three that I just mentioned here on this slide are just paramount for any kind of research that we want to do. The first is the Danish patient registry. That's where we get any inpatient and outpatient contact in the Danish free-for-all public healthcare system. Then we have the medicines registry. That's where we have data on all kinds of prescription. Then we have the Danish registry of cause of death, where we have causes of death, as the name includes. The unique thing about Denmark, because nationwide registries we have in many places in the world, is that we have something that is linked to the registries. It's the mandatory electronic mailbox called the e-box system. This is, as mentioned, mandatory for all Danish citizens 18 years and above. It's linked to the social security number, so we can link the data that we have in the registries to this email system. It's only used for priority communication, so it's where I get my paycheck every month. It's where you get information about when it's time to get your vaccination and so on. And it's a low cost because it's a digital mailing system. So the unique thing about the concept that we have in Denmark is that we can identify people in registries, follow them in registries, but we can also contact everyone in the country with a specific phenotype, regardless whether it's heart failure or amyloid or diabetes, whatever kind of phenotype that you're interested in identifying in the registry, and we're allowed to contact them through this e-box system. So I was told to create a key points learning slide, and I used it to show the outline of what I'm going to take you through, because my talk is mainly going to be about the case studies that we have conducted until now. The first part of the talk, I'm going to take you through and show you some examples of where we just use the registries to identify and invite trial participants, making trials efficient and fast to execute. And that's the DCODE and the coherent trial. Then I'm going to take you through trials where we have used the registries for all parts of conducting the trial. So identifying, inviting, getting informed consent, randomizing, and following them through the registries. And that's the Dan-flu trials and some other trials. Lastly, I'm going to take you through two other concepts where we only use the registries and the e-box as the total intervention in our trial. And that's our nudging implementation trials, where we test how can we increase uptake of a healthy living in the population. And then the last type of trial, where again it's the only intervention is sending out an e-box. It's our trials where we test the efficacy and safety related to the timing of the delivery of drugs. So the first, as I mentioned, it's trials where we are only leveraging this system, the registries combined with the e-box system, to identify, invite, so we can boost inclusion in our trials. The first is the DECODE trial that you can see here. It's a completely conventional executed trial, but the reason why I'm showing you this trial is because we identify everyone in the vicinity of my center with a CKD diagnosis code, and we have several thousand. Then we just invite them through e-box to come to our department to take part in the trial. That makes it very efficient and fast to execute smaller mechanistic trials. The other one is the coherent trial, and that's a trial where we're testing colchicine in hypertension, and we didn't want to include patients who had ASCVD, so any kind of cardiovascular disease. We wanted pure hypertension, and we couldn't really use the diagnosis code to identify those kind of patients because they're being treated by the GPs and they don't put a diagnosis code that goes into the system. So we needed to use prescriptions to identify potential candidates for this hypertension trial. So that's the reason why I'm using or showing both of these. One, we're using prescriptions to identify and invite trial participants, and the other one, we are using ICD-10 codes. But the execution of these trials are completely conventional. The logistics of doing them, it's only the identification and invitation to participate in the trial. Then we're moving on to trials where we're using the registries for all parts of the trial conduct. And the first of these trials that I'm going to take you through is our DanFlu-1 trial. The DanFlu-1 trial was a feasibility trial. It was the first trial where we wanted to test, is it possible to execute a trial only within the registries? So when I say possible, does the ethical committee allow it? Does the Danish Medicines Agency allow it? The Danish FDA allow the safety monitoring being done through the registries? And that was what we wanted to test it when we designed this trial. But the background for why it's impossible to test the high-dose flu vaccine versus the standard dose flu vaccine is because all trials on flu vaccines, and I think actually for all vaccines, they have been powered to assess whether a vaccine reduces the risk of a positive test. None of the vaccines trials have been designed and powered to assess whether they reduce the risk of hard outcomes, hospitalization outcomes. And the reason for this is we need trials that are huge. As you can see, just for a trial comparing high dose versus standard dose flu vaccine would require a sample size of close to 300,000. So that's the reason why they haven't been conducted until now. The reason for doing the DanFlu-1 was purely to test the feasibility. Is it allowed? Will all of these authorities approve a trial like this? And when we're doing a large-scale feasibility trial, we of course, and we get the outcomes for free because we're following them through the registry, we also want to see whether there was ever any evidence of a difference in hospitalizations between those randomized to the high dose versus the standard dose flu vaccine. So how we did it, we identified people through the registries, we sent them an e-box, we guided them towards our homepage where they saw a video of me presenting the information about what the trial was about. They signed an informed consent online, so they haven't talked with a physician, they haven't talked with a nurse at any point, everything is done online. And they, as mentioned, signed the informed consent on this homepage after watching the video. The only security check we had was that they had to answer 2 questions, so we were certain that they were liable in understanding what the video told them and could be randomized. Then we guided them towards our guide them towards our vaccine clinics scattered throughout the country, where they were randomized in a 1-to-1 fashion, individually randomized. My center at Gentofte Hospital functioned at the central trial site. We did all the study oversight, we did all the database management, and we also in Denmark have access to all the electronic health records for the whole country. and all information we got through the nationwide registries. So since it was just a feasibility trial, we decided to invite 34,000 Danish citizens in this age category between 65 to 79 to participate. Of these, we managed to randomize more than 1/3. That's quite a high number just from receiving an e-box to either receiving the high dose or the standard dose flu vaccine. Here you can see the numbers of randomized per daily basis, and the trial was initiated Friday the 1st of October, and as you can see, the first day of randomization, we randomized close to 1,800 participants. And even the Saturday and Sunday, the 2nd and 3rd October combined, we randomized close to 1,000 trial participants. And remember, this is just a feasibility trial. It's not, it's just testing the systems. The unique thing about conducting trials within registries is that you can compare your trial population. So this is our DanFlu trial population with everyone else in the country that could have participated in the trial. So you can really thoroughly assess the generalizability. You can assess the healthy volunteer effect of people participating in trials. We saw that the DanFlu-1 population were healthier than the overall population, but we're quite surprised that we didn't see an even healthier volunteer effect than we actually observed in the DanFlu-1 pilot trial. And as mentioned, because we get it for free, we also assessed whether there was differences in hospitalization rates. And as you can see here from the table, participants randomized to the high dose arm at a significantly low risk of being hospitalized for flu and pneumonia, corresponding to a relative risk reduction of 64%. The trends for the other hospitalizations seem to go a similar direction. And now you can't see it down here, but very surprisingly, the people who were randomized to the high dose arm, they had a significantly lower risk of dying, corresponding to close to a relative risk reduction of 50%. Sorry, I don't know why the reference has come up to in the table. But that was very, very surprising results. And remember, no vaccine trial have been powered to assess the risk of hard outcomes except invested, but that was a specific trial population, right? So we felt that DanFlu-1 was a success. It was approved by the ethical committee, the Danish health authorities. So we moved ahead with designing and executing the DanFlu-2 trial, which is a trial that is sufficiently powered to assess whether a high-dose flu vaccine significantly lowers the risk of being hospitalized for influenza and pneumonia, and it's also co-powered to assess whether a high-dose flu vaccine significantly lowers the risk of hospitalizations for cardiovascular outcomes. And as you can see, we are planning to randomize close to 300,000 participants, as I mentioned, and I think this is probably one of the largest, if not the largest, individually randomized trial ever conducted, and we're sending out 1 million invites for 3 seasons, where we plan to randomize these 300,000 trial participants. This is just to show, comparing to the enrollment graph that you saw for DanFlu-1. This is the season that we just finished, and we only vaccinated for 4 weeks, and actually it was only 3 weeks almost. And you can see, compared to DanFlu-1, the day where we randomized most people was this day, Monday, where we randomized close to 15,000 participants in 1 day. And we managed to randomize this season 160,000 trial participants. So we lagged the last year, the last flu season. That's the next season, then we can present the results. So that was using the administrative registries to execute randomized trials. Another trial that we're doing using a clinical registry is the DanLogic trial. And I'm not an EP physician. People in here knows much more about this device than me. But apparently Boston Scientific's devices since 2018, at least in Denmark, they've had a heart failure alarm called HeartLogic. So it starts alarming the device clinics when these factors, impedance, respiratory rate, night heart rate, sleep, incline, weight, and blood pressure combined shows that the patient is in urgent risk of being hospitalized for decongestion. And as mentioned, we have a big population in Denmark since 2018 who had these devices implanted, but no one is looking at this data in Denmark. So we have a completely hard logic naive population. So the device have measured this in all of these devices since 2018, but no one is using it. So we have the unique opportunity to conduct a randomized trial, identifying all of these 1,500 people, inviting them through eBox to participate in a trial where we just informed it that you either randomize to the user care, what you're doing now, or we will act upon these hard logic alarms. So the trial design is also just shown here. So inviting all of these 1,500 people for us to act on the hard logic alarms centrally from my group at Gentofte Hospital, or not doing anything or just the usual care. And then assess whether treating on these heart failure alarms will reduce the risk of being hospitalized for heart failure or dying. The last of these large outcome trials that I'm going to show you is the Danutio trial, where we identify all Danish patients with HFrEF through the registries, again, invite them through the eBox system, guiding them towards a homepage where they see a video about the trial, giving informed consent online, and then they're randomized to different supplements or placebo. And here we are testing Q10 or selenium to see whether these supplements reduces the risk of being hospitalized for heart failure or dying. And these three examples that I took you through were trials where everything is conducted within the registries. There's no patient contact except for the vaccine, of course. In this trial, we're sending out the medication or the supplements through letters. So we are not going to see the patients at any point, making the conduct of this trial of 5,000 heart failure patients, for almost no cost. Now we have made it to the implementation studies where we only use the eBox system and the letters as the only intervention. We very recently presented this concept that we have coined the Danish NOTCH trial concept, where we identify people through, or we define a research question, identify people through the registries, and then we randomize these people of interest to different letters. So it's purely the eBox letter that is actually the intervention, right? And then we just follow them through the registers to see whether we change their behavior, whether we can get them to live a healthier life, get vaccinated, or increase the uptake of guideline-directed medical therapies. The first of these trials that we executed was the NOTCH flu trial that we presented last year at ACC, where we randomized all Danish citizens 65 years or above, so that's close to 1 million people, to either usual care, where we didn't send them a letter, or 9 different behaviorally informed letters. The primary outcome of this trial was just whether we could increase vaccine uptake and which letter might increase vaccine uptake the most. This is just to show you an overview of the 9 different behavioral nudges that we tested. Our primary outcome, vaccine uptake, was assessed after 3 months. But since we have the data for free in the registries, we of course also followed them in the registries for a prolonged period of time to assess whether changes in vaccine uptake also was associated to differences in hospitalizations. This is to show you the type of letter. So all the letters looked the same. The only thing that differed between the letters was this area where we changed the sentence. And I'm just going to show you 3 examples of the sentences that was included in this part of the letter. And I'm just going to read out loud only the cardiovascular gain letter because we are cardiologists, and of course it's interesting for us here in this room. So we wrote, in addition to its protection against influenza infection, influenza vaccination also seems to protect against cardiovascular diseases such as heart attacks and heart failure. And here you can see the study flow. We had a much larger control group because all the behavioral letters were compared to the control group. So we made that 9 times larger than all the intervention arms. And here are the main results of the NOTCH flu trial. As you can see, we saw that just sending out a standard letter where we didn't have a sentence in the area where we just reminded it's time to get flu 2 weeks prior to the flu vaccination season starting, and on the day of the vaccination season, significantly increased vaccine uptake, but only with 0.73 absolute percentage points. So it was a minimal increase despite being statistically significant. That's also the nature when you do large-scale trials, then a lot of stuff is going to be significant, right? So whether it was clinical relevant might be doubtful. But as you can see, we are also testing it on a background vaccine rate of more than 80%. So it's also hard to move the needle. But even more interesting for cardiologists as us, the most effective notching letter was the cardiovascular gain letter. So just informing the 65 years and above that there might be a link, or there is a link between flu and cardiovascular outcome, was the most effective notch letter of all, despite the fact that, again, the absolute increase was quite minimal, but it was statistically significant. We looked at subgroups, are the specific type of people where we can use the cardiovascular gain letter, which was the most effective letter, where they might be more effective. And interestingly, we saw that it was the most vaccine hesitant. So those who weren't vaccinated the previous season, in that group of people, we actually increased the vaccine uptake with 2.5 percentage points. So it might be using this kind of warning people about the adverse effects of not getting vaccinated. It might be more useful for those who normally don't get vaccinated. And as mentioned, because this is done within the registries, the only intervention we are doing is sending out different letters. We just follow these people for a prolonged period of time to see whether this change in vaccine uptake, it translates into differences in clinical outcomes. But as you can imagine, since it was only very minimal increase in vaccine uptake, we didn't see any effect on the two positive nudging strategies, the repeat letter and the cardiovascular gain letter, on any of our pre-specified outcomes. But since we knew that there was a significant higher effect on those who were the most vaccine hesitant, we also want to see whether in this group of participants, whether there was any signs of a reduced risk of outcomes. And we saw that for one specific combined outcome that we had pre-specified, we saw a slightly lower risk. But again, this is so small numbers, it's only hypothesis generating. So we shouldn't really use this to change anything. So what about this season? Learning from the Notch flu trial we did last season, we executed the Notch flu 2 trial. So it's in the same population, it's the 65 years and above, where we used our successful letters, and we also tested some additional that I'm going to show you. And then we also saw when doing the Notch flu trial that it's especially those that are young and chronically diseased where the vaccine uptake is very low in Denmark. It's between 20 to 30%. So here since, as I mentioned, those that were 65 years and above, we are on 80% of a vaccine uptake. So we did a trial focusing only on the younger chronically ill people. This is just to show the list of letters that we tested. We tested the standard letter and then repeat letter because it was one of the effective, the cardiovascular gain framing letter, and then testing whether is it specifically telling people about the cardiovascular risk, or what about a respiratory gain letter, telling them that they can be hospitalized for severe pneumonia. Would that have the same effect? And then the implementation prompt and loss framing, because those two has in previous trials been shown to be very effective. So we chose to include them in this trial as well. And this, we have already executed the trial. We did it prior to the vaccine season 23. And here you can see for the Notch flu 2, the trial the study flow, where we randomized close to 900,000 this year. And for the Notch flu chronic, so it's the 65 years or the younger than 65 years old with a chronic disease that are also liable for free vaccine in Denmark. In that study, we randomized close to 300,000. So hopefully we can present the results in a month's time or so at ACC, where the readout will be finished. But besides looking at vaccines, using this system of just sending out letters as the intervention, you can use it for a lot of purposes. So you can also test whether you can increase guideline-directed medical therapy in heart failure, CKD, and diabetes. And looking specifically at the CKD population in Denmark currently, we have approximately 30,000 alive at last time when we looked into this in the registries. And here you can see the medication that these CKD patients are receiving. So very few of them are on current guidelines in this patient population. So we designed the Notch CKD trial to test just, is it the patients themselves that you need to prompt or not to say you have CKD, your risk of adverse outcome is serious. There exists new medication now that may prolong your life and reduce your risk, or is it the GPs that we need to nudge to increase uptake of guideline-directed medical therapy the most? So this is a 2x2 factorial where we're both randomizing all CKD patients in Denmark to get a letter about the importance of GDMT, and also randomizing all GPs in the country about the importance of getting CKD patients on GDMT. And this is just to show an example. I know the letter's in Danish. This is the letter that we are sending out to the patients. It's just saying, I'm aware that you guys can't read it, but it's just saying that new treatments have arrived, and that we know lower the risk, and talk with your doctor. You might, benefit from getting on one of these newer drugs. This is the letter for the GPs. It's just stating the guidelines on one page. If you have a CKD patient, you need to get them on these and these treatments if they comply with these biomarkers and so on. So the unique thing about this trial is that since we are randomizing all CKD patients to a letter or not receiving a letter, and the same for the GPs, we can assess, as mentioned, is it the patients themselves that we need to inform about new treatments, or is it the GPs, or is there an additive effect if notching both? And the last thing is that since we are randomizing all GPs in Denmark, as a cluster design, we will actually include all of the Danish population, because all the GPs, they are the ones treating the whole Danish population. So we can also see whether GPs seek out identifying more CKD diagnosis code. We can see whether they start GDMT on other diseases, heart failure, and so on. And we can see whether they start, measuring more kidney biomarkers when they receive this letter in this cluster design. And we have, in this concept paper that we recently presented, we have mentioned all of the many NOS trials that we already plan on doing. And if anyone have great ideas for a NOS trial, please reach out. We can still make the list even longer. The last concept that I want to take you through is using e-box and the registries to test when should your patient take the medication that we prescribe once daily, because for many treatments there is uncertainty in this question. And the specific example that we already have initiated is the aspirin C3 trial. And as mentioned, the reason for doing this is that almost all physiological measures display circadian variation. And the risk of specific adverse events vary over the course of the day. We know that for specific diseases. And one example is the risk of myocardial infarction and sudden cardiac death, which apparently happens more in the morning hours. And the simple intervention of changing the time of drug administration may therefore improve clinical outcomes. But these studies are extremely difficult to conduct, also because they need to be done in giga sizes as well, if you want to test whether taking the drug in the morning or in the evening is most beneficial. And I just want to say that we coined this concept, the circadian chronotherapy concept, and hopefully our concept paper will also soon be online. So here we identify everyone in the country with a specific treatment. So everyone getting aspirin for this specific trial, we send them an e-box saying you're getting aspirin once daily, are willing to be randomized to taking it either in the evening or in the morning. And then we're just going to follow them through the registries. Adherence is going to be assessed through questionnaires, that we're also going to send out through the e-box system. And this study we already initiated, and the target population is almost 33,000 that we are going to randomize in this trial to see whether taking aspirin in the morning or in the evening might reduce the risk of MACE. So just a summary, the major benefits and limitations that I at least can see in executing trials within registries. The benefits, it's a very low cost. As you can see, you can start a lot of trials, testing a lot of hypotheses at the same time. You don't really need a lot of funding to execute these trials. It's much faster patient recruitment, as you saw in DANFLU2, randomizing 15,000 on one day. I don't know any other trial that has randomized that many people in one day. We can the representation of our patient population is probably better. We can at least assess it because we can always compare our trial population with everyone else in the country that could have participated in the trial. It's a lower staff burden, lower patient burden. For many of these trials, people are randomized at home, right? And they don't really have any site visits. We can assess additional subsidiary outcomes. And often for these trials, for example, for DANFLU2, where we're randomizing 300,000, I know that many years down the road, we're going to think of other outcomes that we're going to assess in the registries that we haven't thought of now because the data is being collected regardless whether people participate in the trial or not. We can assess the long-term effects of treatment using the registries. The limitation is it's, of course, limited to the conditions where relevant registries exists. It's less flexible outcome ascertainment. There's uncertainty about data quality and outcomes. It's more difficult with non-approved drugs. The current trials that I show you has either been supplements or approved drugs. It's difficulties to conduct multi-country studies. I hope that we're going to find a solution to that so we can do these kind of studies across borders. And then there are the regulatory and payer uncertainty. And here, the final key points learning slide. So the key points of this talk, I don't normally you read the talker reads them out loud, or I can go through all of them, but so the key points: nationwide registries in combination with the e-box system can be used to identify, screen, and invite trial participants for trials that we conduct with completely conventional logistics, boosting the identification and inclusion. And I just mentioned the DECODE and the coherent trial as these examples. The trials, so we can use nationwide registries in combination with e-box to identify, screen, and invite patients for trial that leverages the registry for all parts of the trial conduction, making it possible to conduct giga trials for almost no money. It's not no money, but it's much less than conventional large-scale trials. And I took it through DANFLU 1 and 2, and then Logic, and then Nutria. And we can also use the nationwide registries in combination with e-box as the sole intervention. And I took you through our implementation trials and also these trials where we test the efficacy and safety related to the timing of delivery of the drugs, the chronic drugs that everyone in Denmark is taking. So the next steps is to assess the regulatory and payer uncertainty, or it needs to be resolved before we can use these kind of trials as the golden standard for non-approved drugs. And that will, of course, be what we would be happy to move the needle and also do, phase 3 trials with unapproved drugs. So there's a lot of people I need to thank, and as Richie mentioned, all my fellows and all of my people that do all of the hard work in my group, all the many people that I collaborate with around the world, my employers, my current and previous mentors, and all the foundations that funded this research. So thank you so much again. It's a great honor to be here today, and I've been very happy to present you these results.
Thanks so much, Tor. That was it's an incredible body of work. We usually open it up for questions, but maybe I'll just lead with one. I really liked the nudge CKD trial and we don't often think about provider level interventions, but how you work that in. I'm just wondering, is is there a lot, in the US, we always talk about how there's so much heterogeneity in provider care quality and delivery of care across it. Do you see that in Denmark? Are there specific provider target populations that you're trying to improve care delivery among, or were you just trying to sort of build that into the trial out of interest?
That's a great question, and the short answer is that I have no idea, but I think we should, Richie, as one of the projects, we should of course assess this prior to showing the results of this trial, because I would probably imagine that we don't see the same kind of disparity or heterogeneity in Denmark because our system is so much different. As the preliminary analysis that you have conducted, there are so many differences in our healthcare systems but I don't know, but we can assess it because the data from these healthcare providers is already in the registries. So, it's just defining, how to assess it. And that's also one of the limitations within the registries. We are limited by the data that is within the registry. So we have to find ways to assess that. And I know that you're brighter to figure out how we potentially could do that in these registries. But that would be a great addition to the trial. Yeah.
I was fascinated that one trial, 30% see that reproducible along other trials.
So that was when we did our feasibility trial, the DanFlu-1 trial. I think there were many factors that led to such a high recruitment rate, from invitation to actually being randomized. First of all, this was done on the first season of the COVID pandemic. So the vaccine uptake increased, in Denmark from close to 70 to this 80%. So there was a lot of focus on vaccines. The other thing is that, of course, it's easier to conduct a trial where, and as you can see, the Danish population in general are very willing to be vaccinated. They couldn't get access to the high dose vaccine because it's not included in the Danish vaccine program, only if they participate in the trial. So that's again another benefit of those who are willing to either they get the standard dose that they would get in the public program, or the high dose. So I think there were factors that made this extremely high, because we don't see similar recruitment rates in many other. We're doing a trial in COPD. Recruitment rate when we send out invites to this population that is very sick, we see much lower recruitment rate. So you're right, it depends on the intervention that you're testing and the specific trial population. I think the more sick the population, the less effective, inviting through the e-box system probably is. So that's a very important point when setting up these studies. Yeah.
Is it just the population really big systems, or is there family involvement?
No, that's a great question, and we, of course, leveraging the system where everything is done electronically, you bias your study population towards those who are tech savvy, right? It is the ones that can figure out this, but the e-box system, the great majority actually of the elderly use it. It was introduced, I think, in the beginning of the thousands, or I think right before 2010 or something like that. And in the beginning, because you can opt out, then you just get all the letters that we send in paper. So you can't really opt out of getting a letter, but we know that if you get the invitation, with a link going to a homepage in a letter, the likelihood of you participating is very low compared to those that get it on the computer or the phone. So you're completely right. We are biasing our study population, but currently it's only 10% of the elderly that we invite for our DanFlu trials that actually have opted out for getting it electronically and that feel that they can't go in and do it. And if they can't, there's always the option you allow a relative to access the e-box system for you. And that is definitely also one of, we don't have any measures of that in our trials. whether, you know, relatives, but that is allowed in the system, that relatives can be given the authority to act upon the elderly, you know, using the system. So, yeah.
Spectacular, really great. With all that data, you focus on the salutary effects, beneficial effects of these various interventions. With all that data, you can begin to look at agency as well. And I was just wondering your thoughts about that, and then how do you reproduce it with a smallish number of people?
Yeah, no, but that's a great point, and I think
I'm joking, but there are going to be untoward effects.
yeah, and just like the beneficial effects, we also get that data within these registries. So, for example, that's a great point in flu 2. Remember, this isn't the COVID vaccine. We haven't done any trial. Yeah, no, I agree. And the very interesting point is also the nudging strategies, because we have seen signs that improving one health seeking aspect of healthy living might reduce, you know, other things. So no, but you are right. We've actually seen, we haven't published it yet. We are currently trying to publish the detrimental effect of notching, you know, flu vaccine. I can't say too much, but it affects other vaccines, you know. So guiding people's attention towards one vaccine might actually damage the uptake of other vaccines. And we didn't know that, so it's a great point, and we saw that, and that's also why now when we discuss, because the health authorities are very interested in these, because they just want to increase vaccine uptake. So now we're discussing whether, if we're going to do a notch flu 3, whether it should be multiple vaccines that we need to state in the notch. So you're completely right, but the amazing thing is that you can assess everything, right? You can assess whether SGLT2 increase or decrease outcomes, myocarditis, whatever. And we didn't pre-specify that detrimental effect, but we did see an effect on other vaccines that we didn't expect. Yeah.
That was amazing podcast. I have a sort of a related question on that. As your list of trials grows, have you thought about sort of multiple trials, overlap, multiple participation for a given patient, and how that might lead over? I imagine it's really complicated, but I can imagine there are lead over effects.
Yeah.
Even when you think about conclusions drawn from an observational registry within which people get randomized to certain things.
Yeah, no, that's a really great point. We are actually, because our first notch trial was the notch flu trial that we finalized last year. So notch flu 2, we are actually testing that. We have pre-specified whether the treatment effect of notching potentially, you know, is heterogeneous, you know, between those that we notched it last year, or of course that is within the same theme. But you're completely right, when we are notching the CKD patients, and we're also going to do notch heart failure, right? You know, many of them are being notched, but the unique thing is that you can assess the effect directly, right? Because we can identify all the 10,000 that we notched, you know, in the same trials, because we have access to that in the registry, so we can assess that. My main fear is just that this system that is used for priority mail, it's not a normal email. You have to log in with your social security number. You have to give a electronic signature every time. So it isn't, you know, real. My biggest fear is that doing all of these trials, both using them for inviting people to conventional trials, doing the vaccine trials and the notching trials, that we might make the e-box system more into a regular mail system, that people, they get fatigue of receiving all of these, you know, notching. But until now, at least, we haven't seen, and that's not published yet, we haven't seen a fatigue in the notch flu trials, where it is the same that we notched. We haven't seen that the notches are less effective in those that actually received a notch letter last year. So that's at least encouraging, but you're completely right. We will be randomizing that same people in 10 different trials. potentially, right?
This is really fantastic, Laura. I think that, you know, there's a group in the US that involves the FDA and CMS, academics and industry that often get together and we talk about how come we can't have a data system. One of the barriers in our system and us from being able to create this sort of, well, I'll say that it's something that we're working toward, because all the data elements, the types of data sets that you have that create this system, we have similar data sets like that in the United States. And I think one of the challenges, there are many, some of them are cultural differences in comfort with privacy. There are differences in participation. I don't think you would get 30% response rates, for example.
Not without incentive.
Without incentive, and I was going to ask you about incentive. But also, the agencies that have been responsible for creating those data sets, one, have not created those data sets for the purpose of research. And so those data sets don't exist for that purpose. They exist for billing and sort of, you know, administrative reasons that have nothing to do with science. And so those individuals who run those data sets are not interested in science, nor do they even understand why this might be useful. So I'm curious, historically, when these data sets were originally created, was this envisioned as part of what the purpose would be? And if not, how did it come to be that they were, what was the breakthrough that allowed something? Machinery is incredible, but it also probably took a lot of foresight and vision from the people who created them if they weren't originally created for this purpose.
But so these administrative data sets are exactly, you know, created for the same purposes as yours. None of them has been created for research purposes. So that's just you know, the response to the first question. So it hasn't been created for anything like this. And actually, when I moved back from Boston, you know, think about we need to, because you probably have seen a lot of observational data come out of Scandinavia and other nationwide registries looking at you know, observational questions. So they have been used for that for many years, but the new thing in this is, you know, adding the prospective randomization and you leveraging the e-box system, and we, you know, I think other Danes are gonna see the benefits, and I'm not gonna be the only one doing these kind of studies. But the big hassle for me was figuring out all the laws of, you know, the first hassle was just figuring out, you know, are we allowed to contact people with e-box? You know, then we got the Danish data agency to say, yeah, you are, if the ethical committee approves it. Then we went to the ethical committee, will you allow it, you know? And so that took, you know, the 2 years prior to us setting up the first trial. And that was a lot of the work going into the DanFlu-1 trial. It was just going through all of these different agencies, figuring out the laws and the rules about this. And then, you know, the DanFlu-1 opened the door for us to do, you know, I think we're doing 12 trials, you know, currently leveraging these system, right? So none of it has been created for it. I think maybe in Denmark, the laws for privacy and so on might be less so, because the first thing when we got DanFlu approved and we were initiating that, I contacted my Scandinavian, you know, colleagues to say, can we do this on a Scandinavian level? So instead of, you know, doing DanFlu-2 with 300,000, where we need to do it over 3 seasons, we can do it in all of Scandinavia. And they have different laws. So they were stopped quite fast. You know, they were not allowed. They also have the e-box system, but they're not allowed to send it out because in Norway they have very strict privacy laws. So it depends on those kind of national laws, you know, whether it's possible. But I think you know, the only reason why we succeeded was because, you know, we pursued and tried it. But I think that it might, if it's legal in Denmark, you know, why shouldn't it be legal in other countries? But I yeah, I don't know. You had more questions probably than
No, that's great. Yeah. You know, so we in Massachusetts, we have an all payers data set that collects all the outcome data, hospitalizations, inpatient and outpatient visits for everybody who had, and everybody in Massachusetts basically has some insurance. And so what we've been trying to do is to link that data set for follow-up with multi-institutional kind of cardiovascular data sets. process alone has taken probably 2.5 years.
Yeah. Yeah.
And we're not there yet.
Yeah.
And so this, I think what you're saying is that it's that upfront work to create the machinery that is really the challenging one. But the challenges we run into is that the organizations that we talk to are not research organizations.
Yeah.
So it's creating every step is creating a new process.
Yeah.
That they have to get in, buy-in,
Yeah.
and then there's going to be the verification.
Yeah. The benefit here might be the fact that we've used these registries for retrospective assessment for many, many years, right? So there was a whole institution for doing retrospective assessment as a whole. The Danish Data Agency, they were very used to receiving applications to do a retrospective, study. So that might have been, at least one easier path on the way. But I don't know. Yeah.
For that was fantastic. I have a slightly niche question, reflecting the patient's comment on psychology care across physicians. Have you seen a differential effect on like native versus foreign-born Danish citizens, specifically folks who maybe that's not solid with the system or the language? So we're talking about 10% of your population. If there's a signal there that these numbers are different, you're probably underserved.
That's a great question. That's really, as I mentioned, as one of the limitations is that you're limited to what is already in the registries. Often we identify surrogates. For example, for the coherent trial, we said, okay, just looking at prescriptions of 2 antihypertensives, then that must be a high likelihood of being a hypertensive patient being treated by the DPs. So I think until we find a surrogate to identify those groups, currently there isn't a variable in these registries, saying. But this is also, it's quite new for us. And as I mentioned in the beginning, every time we do a study, when you guys come with a question and want to test it, then we go back and figure out, is there a registry where we somehow can assess that as a surrogate measure? And that's, an extremely important and relevant question to assess as whether there's a heterogeneity in any of our studies that we do. So a great question, but currently I don't know.